Welcome to today's virtual event on the growing role of private equity in healthcare. My name is Tim Stum. I'm the editor of Wisconsin Health News. Thank you all for tuning in. We have a really great panel with us today to talk about this important topic. I am honored to introduce Rick Abrams, CEO of the Wisconsin Healthcare Association, Dr. David Blumenthal, former president of the Commonwealth Fund, Tami Jackson, Public Policy Analyst with the Wisconsin Board for People with Developmental Disabilities, John Russell, CEO of Prairie Ridge Health, Dr. Jason Sansone, President of the Orthopedic and Spine Centers of Wisconsin, Dr. Jason Scalise, Chief Growth Officer for the Healthcare Outcomes Performance Company, and Sean Kirkby, Senior Editor for Wisconsin Health News, who is moderating today's discussion. Before we get started, though, I want to thank our very generous sponsors of the Wisconsin Health News virtual series. We really view these events as an extension of the journalism that we produce in our daily email newsletter, and it truly would not be possible without the generous support of our sponsors. So a huge thank you to Aurora Healthcare, AARP Wisconsin, Anthem Blue Cross and Blue Shield of Wisconsin, Amplify Health, Hush Blackwell, Quartz, and the Alliance. Wisconsin Health News is an online nonpartisan news service. In addition to hosting events like these, we also publish a daily email newsletter. If you're not yet a subscriber, I encourage you to sign up for a free trial, which you can do on our website at wisconsinhealthnews.com. And I want to give an extra thanks today to Quartz, today's featured sponsor. We are very grateful for all of their very generous and continued support. And here to say a few words is Miranda Tank, Director of External Affairs for Quartz.
Thank you, Tim. It's an honor to introduce Quartz today as a featured sponsor of this year's virtual event series. For those who are not already familiar with Quartz, we're a locally based, provider-owned health insurance company dedicated to ensuring all our members have access to a life well lived. For over 40 years, we've provided our Wisconsin neighbors access to exceptional doctors, hospitals, and affordable healthcare programs. Alongside our provider partners at UW Health, Unity Point, Advocate Aurora, and Amplify, we proudly serve members in communities across Illinois, Iowa, Minnesota, and Wisconsin. Our local roots and our unique collaboration with our provider partners empower our members to live healthier because we're with them on every step of their wellness journey. Our commitment is to serve our members and our community with quality care and to give back so our neighborhoods shine brighter. At Quartz, we believe that together we can build a future where well living is always within reach for all our communities. Quartz was proud to support the Wisconsin Health News virtual event series this year to help further discussions and raise awareness about important healthcare topics that impact the members and communities we serve. This year, the virtual event series has covered topics that affect Quartz's member population, provider partners, and clinical priorities. From challenges facing rural health systems to the cost of prescription drugs to new advancements in healthcare innovation. This year's event series has helped advance the conversation about crucial topics facing Wisconsin's healthcare industry. Quartz would like to extend our gratitude to Wisconsin Health News, all the other sponsors of this event series, and all of this year's featured speakers for helping further awareness of the issues impacting the communities we all serve.
Well, thank you, Miranda, and thanks again to Quartz for all the generous and continued support. And with that, I'm going to hand it over to Sean to lead today's discussion.
Thanks, Tim. So for-profit healthcare and long-term care have drawn more attention recently, especially around the role of private equity firms and private equity funds and advisor pools to gather money from investors and focuses on long-term investments. A typical strategy that they sometimes employ is to take a controlling interest in a company, help manage it to increase its value, and then sell. Private equity has drawn increased scrutiny for reasons we'll dive into soon. In Wisconsin, 0.3% of nursing homes and 0.8% of hospitals are controlled by private equity, according to the Private Equity Risk Index. Wisconsin ranks among the top 10 states with a share of its population in the metro area where a single private equity firm controls more than a 30% market share of one or more physician specialty practices. Private equity also has a stake in autism services in the state, dental organizations, and mental health care providers. Our panelists are going to take a deep dive into this topic. And I wanted to start with Dr. Blumenthal. You've written about this extensively, and you've known that private equity investment in healthcare is not new. Can you talk about what are the recent trends and why are these drawing increased attention now?
Well, thank you. It's great to be here with you. I'm sitting here in Cambridge, Massachusetts, and I don't pretend to know what's going on the ground in Minnesota, so I'll be speaking generally. As you pointed out, private equity is not new as a form of ownership in healthcare. It means just simply that there's a private owner of a healthcare facility or a practice. That's typical of physician ownership of practices from time immemorial, and there have been many small privately owned hospitals and nursing homes for a very long period of time. What's characterized these previous types of investments is that they were generally made by people who intended to stay with them and grow them, and had a presence in a community to which they felt some accountability. What we've seen recently is that that same mode of ownership has become part of the work of large private equity companies like Blackstone, KKR, and I could name others, that have no special interest in healthcare and no commitment to healthcare for the long term. Their focus is on a quick return on investment, and they will do fairly radical things from a local standpoint in order to realize that investment. We've seen that locally here in Massachusetts with Stewart Healthcare, and which has kind of become a poster child of the misuse of that form of investment to the detriment of a community, bankrupting hospitals, closing them down, leaving communities without access to care. And that style of investment, rather than the legal form of investment, is what has come to characterize private equity and the concern about it. It's nothing illegal about it. It's a behavior on the part of investors that has become of concern. And there is something, I'm a physician, I practiced primary care for 35 years. I think there's something special about healthcare, and I think most people think that too. It is not a commodity. Practices and facilities are not commodities like muffler shops or fast food outlets. They have community links, community responsibilities, community commitments, and people depend on them for life and death services. And to treat them like any other kind of service to make a quick dollar just rubs people and legislators the wrong way, which is why you're seeing the reaction that we are seeing, not only at the federal level, but in dozens of states across the country.
Sticking with you for a second, Dr. Blumenthal, can you talk a little bit about how widespread some of these practices are? Like, what have we seen in terms of, like, at a national level, we're taking a national look at this, in terms of increased investment from private equity firms in healthcare?
Well, it's still a relatively small part of the total healthcare system. It varies enormously by state. So there are some 5 or 10 states in which private equity investors own more than 15% of the hospitals. Minnesota is not one of them. Texas and Oklahoma and Louisiana are examples where that is the case. So there's an enormous amount of variation from state to state. Texas has the most private equity owned hospitals. California has close to that, but as a proportion of their total hospitals, it's far less than in Texas. There is also, of course, this is a changing phenomenon. There's a lot of investment in private equity in physician practices, and some fairly classic cases of so-called roll-ups in which a single company purchases multiple practices to the point where they begin to have a competitive advantage that sparks antitrust interest on behalf of state and national authorities. And that, of course, is well characterized by the United States Anesthesia Partners, which was sued by the Federal Trade Commission in Texas because it was felt by the FTC that it was developing a level of control over local practice that gave it unfair market strength to raise prices. And so that is another concern, independent of the concern about leaving communities with less in the way of resources. It's the question of whether some private equity companies have become anti-competitive in their practices.
Thanks, Dr. Blumenthal. Rick, could you talk a little bit about what's driving this type of investment in long-term care? Like, what are we seeing in Wisconsin?
Oh, sure. Well, first, I want to just thank Wisconsin Health News, the sponsors, particularly Quartz, today. I don't disagree with Dr. Blumenthal's description, okay, of what's going on out there. But it's really, really important for everybody who's participating today that long-term care in Wisconsin is not at all like that. Okay. Are there transactions involving the transfer of ownership between a for-profit nursing home or assisted living and or a not-for-profit? Absolutely. But these are not Wall Street firms. I mean, they're not the Blackstones or the KKRs of the world. These are private family-owned firms, okay? Some Wisconsin-based, some not Wisconsin-based. But Sean, in direct answer to your question, there are 3 or 4 things that are driving all of this activity. Okay. The first is regulatory complexity. Okay. Whether you're, especially in the nursing home setting, since the passage of the Omnibus Reconciliation Act of 1987, it is a very, very difficult environment for a provider, for-profit, not-for-profit, to really be successful in. And if anything, over the last 35 or 40 years, things have gotten more complex and more difficult, not less complex or less difficult. Workforce is driving this too. I mean, workforce shortages, okay, whether it is in the clinical setting throughout healthcare, is a real problem. It's going to continue to be a problem. I think that's driving it too. To a degree, finances is driving all of this activity. Now, I can't thank Governor Evers enough. I can't thank Governor Walker before him. And I especially can't thank the legislature, both sides of the leadership, both sides of the aisle, for the attention that they've given long-term care, both our nursing homes, but also family care from the financing side. I would dare say that while we struggle or providers struggle in certain instances, particularly on the family care side, all of the activity, transactional activity, I think would be far greater. The closures would be far greater. The downsizing would be far greater, but for the recognition and attention that our legislative leadership and our governor, our last 2 governors, have given this point. And so I think that what is driving all of this activity is a combination of those 2 or 3 things. But at the end of the day, what all of these things also drive is that they suck the life out of any kind of innovation that we can do in long-term care. Before we got on, I talked about, I'm at a conference and I talked about attending a session on employee stock ownership programs, because government financing, is such a major driver, okay, of the financing of long-term care. An ESOP isn't even an option. I don't know if it's the example. I don't even know if it's a successful example. But my point is that we need to loosen up the reins, not tighten up the regulatory reins, so this kind of innovation can take place. And the last thing I'll say, at the end of the day, it's not about your tax designation. It's really not about the regulatory environment. It is in part about the financing, but at the end of the day, providers of long-term care, providers of healthcare generally, okay, we have a legal, an ethical, and a moral duty to provide quality care to our patients or our residents, our customers, and that's what it's all about. And with all respect to my fellow panelists and your audience, that's what we gotta continue to focus on. High quality, cost efficiency, and that gets us success, not only in Wisconsin, but across the country. So again, I appreciate being here.
Thanks, Rick. Dr. Scalise, could you talk a little bit about Healthcare Outcomes Performance Company? What is its relationship with private equity?
Sure. Thanks for hosting and thanks for having me. So HOPCO Healthcare Outcomes Performance Company is a large musculoskeletal focused physician-owned organization that has a national and international presence that's designed to be able to help improve value and quality across the musculoskeletal care continuum by engaging with physicians, engaging with payers, and engaging with health systems, all key stakeholders. HOPCO, I'm an orthopedic surgeon, practicing orthopedic surgeon by background, and HOPCO is a physician-owned organization, as I said, and our relationship with private equity is focused on bringing in private equity funding to help execute our strategies in a way that would otherwise be cost prohibitive, resource prohibitive. So, for example, and I just to sort of step back a little bit from my comments and leverage what's been said already, there is, in many ways, we find ourselves in healthcare at this sort of dichotomous position in that I think many would agree that increased investment in healthcare for innovations and just to use examples, data systems and the ability to connect providers to their patients and providers to providers, there is a great need for focus, for hard work, innovation, and financial resourcing to be able to develop those types of programs. I don't think many would argue that there's more than enough free time and resources and free dollars in healthcare, then everybody has what they need. I think it's kind of the opposite. So in our organization, as we're in orthopedics specifically, there's a great need to be able to find savings, shift the focus of healthcare from what may be clinically unnecessary expensive care, it's specific to orthopedics, into more less expensive but still clinically optimized outpatient care, for example. And just using those examples, a lot of that shifting, a lot of our work around finding where value is and connecting providers to where value is in healthcare and where greater outcomes can be identified requires a tremendous amount of investment and resourcing, far beyond what physician organizations have the ability to do. Hundreds of millions of dollars as data systems and quality systems and longitudinal tracking and so on. The ability for like-minded physician or clinical organizations to collaborate at that level is very limited, and limited generally by bandwidth and resources. So to go forward to answer your question, our goal was to be able to utilize a source of funding to execute on our strategies, as opposed to looking at outside funding into our organization as the strategy. And I think when organizations think that is the strategy to get outside funding, I think they've missed the point. And I think that sets them up for some of the challenges that we see when there's outside investment into, in this case, healthcare organizations. The alignment, the incentives, and the rationale can be a little bit askew. But any tool used in an inappropriate way will probably lead up to less than ideal results. And I think using the tools of bringing in not only outside funding, but bringing in outside resources and relationships and mind share can help elevate what can often be in healthcare specialty care, like orthopedics or gastroenterology, can sometimes feel and quite function like a cottage industry. And elevating that cottage industry into a much more organized and scalable organization requires a lot of dedication, both on work, resources, and personnel.
Thanks, Doctor. Dr. Sansone, can you talk a little bit about why you all decided to partner with HOPCO when you were launching Orthopedic and Spine Centers of Wisconsin?
Yeah, absolutely. I appreciate being invited to the panel, by the way, and thanks for the question. So, yeah, I'll spare the audience all the details, but I think when we were staring down the barrel of opening our own practice and trying to do all the blocking and tackling necessary to execute on strategy, which, you know, includes IT infrastructure, includes payer contracting, includes rev cycle management, all these types of things. We knew that we didn't have internally, we didn't have the expertise or resources to springboard off of Dr. Scalise's point, both time-wise as well as capital intensive resources to do this on our own. And so, you know, really from orthopedics, if we look across the landscape nationally at the companies that provide kind of the full on-suite turnkey solution for back office, really Hopco is kind of the synonymous with that for orthopedics. They're the best in the business. As it relates to specifically private equity and how that interlaces with our relationship with Hopco, you know, I can tell you that I've never once talked with, nor interacted with, nor been on a meeting with anybody from a private equity firm. And again, I think the devil's always in the details, right? I think it's easy to lump private equity into a single group and villainize them, for example, for some of the bad actors that we've seen. Let us not forget that there's also bad actors in the not-for-profit world and in the for-profit publicly traded world, right? All these various sources of funding. I think, you know, it's to one of the panelists' earlier points, like, let's separate the behavior from the label, right, of who that behavior is coming from. But from our perspective, you know, we've benefited from the private equity investment into Hopco just by virtue of the fact that it allows Hopco to build out their infrastructure to do the things that they need to do to help us. From our perspective, we are 100% owned by ourselves. And so Hopco is ostensibly our management company that we pay as part of our own P&L. And as I say, there's very little, in fact, no interaction on a day-to-day transactional level as it relates to a private equity firm trying to dictate how we go about doing our business and whatnot. So I guess in the short answer to your story is we partnered with Hopco because they're the best across the country at doing this. And to stick with the theme, we have not in particular been interactive with private equity as it's often described.
Got it. Thank you, Doctor. John, could you talk a little bit about Prairie Ridge Health's interaction with private equity-backed organizations? Kind of what's been your all's experience in this field?
Yeah, thanks, Sean. Actually, I'd like to back up to the why private equity is increasing in Wisconsin and across healthcare. And simply speaking, it's because they found areas of healthcare they can make a 20% return, give or take, each year. I mean, let's be honest, that's the fact. And that's, by the way, that's not necessarily driven by anybody on this panel. That's driven by government intervention in healthcare, how the system's set up. They're cherry picking opportunities to make a return. I'm an open market person. I'm a capitalist, but I will say this: healthcare is not open market, and it hasn't been since Medicare. So back to your question about Prairie Ridge, we are a community-owned hospital that's partnered with SSM Healthcare. We have no relationship with private equity at Prairie Ridge Health.
Got it.
Can I cut into Sean?
Sure. Go ahead.
I think we should absolutely underscore what John was saying is I agree completely. I think most everybody on this panel would agree, right? Like, free and open markets are what make markets work. I think most of us would agree. Perhaps some people would disagree. But there's been price distortions in the market due to varying levels of government intervention and regulation and so on and so forth, which is well-intentioned. I'm not disputing that. It's very well-intentioned, right? It feels very good to, and is obviously necessary in some sense of the word to appropriately subsidize various things and to bring a regulatory framework with the hopes of ensuring that there's equitable access to care and quality across the country. But one of the things that does happen when free and open markets aren't allowed to exist, and even more specifically, price transparency, right? Quality transparency, being able to put the onus on the consumer to choose their healthcare, creates a lot of these price distortions and avenues for arbitrage as it relates to investment and whatnot. So I agree completely with John.
Thanks. Dr. Blumenthal, I see your hands raised, so let's get to you, and then I'll get to you, Tami, too.
So if we want to have a discussion about the role of markets in healthcare, we can have that discussion. But I think we can separate private equity from that discussion. The abuses that private equity has demonstrated have nothing to do with fair functioning markets. They have to do with the exploitation, in some cases, of a business that is primarily about serving people and keeping them healthy. And the idea that somehow healthcare investors should be entitled to huge returns on their investment, even at the risk of bankrupting services they're investing in, I think is a misimpression. We have the most innovative and the most dysfunctional healthcare system in the world. The Commonwealth Fund just released a report showing that once again, the United States, compared to other high-income countries, has the worst outcomes of care, the highest levels of preventable and treatable mortality, the highest barriers to access from cost, the least effective coverage, and we also have the most market-friendly country in the developed world. So if we want to look at government as the problem here, we're looking at the wrong victim, wrong villain. It is the market unleashed, which has created the Stewart healthcare fiasco in Massachusetts, and which has, not in all cases, but in some, abused the trust of local communities in their local physicians. And I think that it's easier always to point to government. But in this case, government is the backstop against further abuse.
Thanks, Doctor. Tami, wanted to talk with you a little bit. The Wisconsin Board for People with Developmental Disabilities submitted testimony to federal agencies earlier this year on private equity and long-term care in Wisconsin. Do we know how widespread private equity is in Wisconsin? Why or why not?
Well, this is one of those questions where widespread and also no one knows, right? Let's start with what we do know. We do know in Wisconsin that private equity firms have already bought some home and community-based service providers, and that includes personal care agencies, fiscal agents, and residential providers, adult family homes, community-based residential facilities. And there are some instances where assisted living or rehab facilities or nursing facilities that may serve people who are both private pay and Medicaid participants have some investment. I do think that what is unknown in Wisconsin and everywhere is the scope and scale of these acquisitions. The state really doesn't have an ability to understand that, nor does the federal government at the moment. And advocates certainly don't, and consumers don't either. And the other piece of that is that the full business portfolio of that private equity firm is also unknown. What are the contractual relationships? What else do they own? What's their scope of operation in other states and their performance in other states? These are all things that are kind of not able to be understood, which is part of the reason the federal government asked for comments. What we do know is that my counterparts in all 55 states and territories are extremely concerned about this issue. And we're not the only ones. Lots of advocates for older adults, people with disabilities are starting to really track not only private equity, but also business practices that you may see in a for-profit or nonprofit model that are really jeopardizing potentially quality of care. I was just on a webinar last week, and I think the breadth of private equity involvement across the healthcare sector was surprising to me. It's not only hospitals and home and community-based long-term care, nursing homes, mental health, methadone clinics, fertility care, prison health care, ER services, hospice. And that, to me, as an advocate, is really eye-opening, because many of those areas really serve marginalized and vulnerable populations of people. And sometimes those are populations of people where negative outcomes might be more expected and not as readily questioned. So, advocates are really keying in on this as, okay, we have populations of people in some cases that have high needs, that are high cost for a long period of time. why is it that folks see this as a money-making prospect? How are they going to make money off people who really need lots of care? And I think the answers that we are starting to see, in terms of the growing body of research out there, there's a kind of a familiar correlation between private equity acquisition and declining quality of care, either maximizing profits by cutting costs, maintaining fewer or less qualified staff, choosing the clients who can pay the most and need the fewest or the lowest cost services, and billing practices like upcharging. And I think your panelists have already talked about, market share, but we also see this as a big challenge, because whenever there is only one game in town, we see competition being potentially reduced or eliminated, either through different services or changing who you're serving. And I think for us, especially for people who really rely on local, long-term care service providers in the community, we're very concerned that that gives those entities a lot of leverage to determine who they serve. And for us, a lot of the people who are served, again, high needs and on Medicaid, may be the least attractive to some of the folks that are interested in acquiring things. And I do think that Dr. Blumenthal's point about, the community connection in healthcare is very important, because I think that one trend we have seen across the country is that private equity seeks out businesses that have good reputations within the community, and those are often built over years or even decades. And those qualities that attract those are maybe the ones that are often at risk and might be sacrificed to improve profitability. And especially when, there's ownership changes, we see some downstream effects of, invalidated contracts, leadership turnover, workforce churn, and ultimately there's been some indications that continues to spiral downwards in terms of quality of care.
Got it. Thanks, Tami. Rick, I see your hand raised. Do you want to respond?
Oh, sure. I think that we really have to guard against making sweeping generalizations. Again, as I said at the outset in my remarks, at the end of the day, it's about whether or not that provider, that entity is providing high quality of care, period. A lot of these transactions that are going on, and again, only talking about Wisconsin, and I'm only talking about facility-based long-term care, are as a result of regulatory complexity and or financial challenges. In a lot of these cases that I'm aware of that involve, my members, generally, if these transactions do not proceed, and they particularly occur in very rural areas, if that nursing home, the only nursing home in town, if that transaction doesn't occur, that facility closes. People lose their jobs, but even more importantly, those people, who are cared for in that town, or that village, and the people who work there lose their jobs. But the ability of ready access, which I believe we enjoy in Wisconsin, is compromised. And so those are the things that are driving it. I mean, to paint the picture of a private equity firm, again, of the Wall Street variety, just swooping in to the rural area in Wisconsin to try to snap up these facilities, that's not a true picture, or it's not the picture that I know. But again, what drives these transactions, and it's accelerating, is just the inability to continue to operate that facility so that it is sustained.
Got it. So John, Rick brought up some points about rural Wisconsin. Could you talk a little bit about how nonprofit hospitals feel about some of these trends? Do you have concerns about this growth of for-profit healthcare or private equity investment?
Yeah, maybe a couple things first. So on Rick's point about mostly for-profits going into rural communities, I know that happens, and some of those facilities would close without a for-profit nursing home entering those markets. I would say, though, the formula is pretty simple, right? I mean, it's a reduction in access and it's a reduction in cost in order to make it work. And that can and does impact quality. And it can and does impact access. That usually means Medicaid. It means complex Medicaid patients that aren't being served. So that does and often does happen. So your question about how does rural healthcare feel about it, I guess I'd ask you to ask the Chippewa Valley. The Oakleaf. First of all, let me say this about Oakleaf, and I'd say this about Dr. Sansone. Excellent group of surgeons up there. I've known Jason about 15 years. He's very good at what he does. But nonetheless, the impact on Oakleaf in the Chippewa Valley was profound. A 30% operating margin in that facility. Sacred Heart had a negative 47% operating margin. They took very little Medicaid. They skimmed the easy cases off the top and left their safety net hospital to take the rest of it. That impacted not only Eau Claire, but that impacted all the communities surrounding that. And there's probably plenty of people listening on this panel who are listening very carefully for that exact reason, because of the Chippewa Valley.
Thanks, John. Dr. Sansone, do you want to kind of respond to that? I mean, there's some evidence suggesting that private equity ownership can lead to an increase in prices for consumers. Do you share that concern at all?
You're on mute.
Shoot, that was the most profound thing I'll say all day, and and now I lost it, and I was muted. No, I appreciate the question. So, a couple things. One, I think, again, let's be impeccable with how we slice and dice this data and such, right? So I did read the large 65-page report that you sent out, Sean, about monetizing medicine that was written by the Petrus Center and American Antitrust Institute, lead author Scheffler. And I thought it was actually a remarkably well done piece. One of the points that I would make is that the authors there say on multiple occasions throughout the report that oh, by the way, as they're kind of getting after private equity, that for example, it's important to note that the consolidation of and lack of competition in physician markets is an issue that goes beyond private equity investment. For example, 2 studies that systematically reviewed the evidence on the impacts of hospitals acquiring physician practices found that these acquisitions were associated with higher physician prices and expenditures with mixed results on quality. So I don't know that the concern about cutting costs and worsening quality and decreasing access is germane specifically to private equity investment. So that being said, in orthopedics, it may in fact be slightly different than it is in other specialties. And as a subspecialist, I can only really at least knowledgeably comment on orthopedics, which is to say that what we're seeing in orthopedics is a transition, as Dr. Scalise alluded to earlier, from the more expensive inpatient world to the less expensive outpatient world. We're able to do total joint replacements now. It's by and large on an outpatient basis. When I was a resident, which was only, well, every time I count, it's longer, but about 12, 15 years ago now, it was routine to have somebody spend 3 nights in the hospital after a total joint replacement. And so as that transition's occurred, are there ways that we can, in fact, accelerate the pace of moving cost of care from expensive inpatient settings into more outpatient settings? I think, the hope is that, yes, we can, as a country at a macro level, do that. I think that if however, there is a way to accelerate that transition into that less expensive outpatient center, thereby driving more value, it's a benefit, right? I mean, I don't think anybody on this call would disagree with the fact that we have an existential crisis in this country on our healthcare spend. I think all of the speakers would agree with that. This is not sustainable. It becomes, actually, if you really extrapolate it out, it becomes a national security issue as it relates to defense and entitlement spending over time. And so what can we all do to make that transition towards a higher value healthcare system more palatable? And what can we use as sources of innovation and sources of funding in order to achieve that end. I think it's important to everybody in this country that we do that, because as Dr. Blumenthal alluded to, we're not doing well with it right now. We have the most innovative system in the world, and yet the most dysfunctional.
And I would just say also to also answer that question about what we've seen, there's actually a fair amount of data now over the last 10 years about what happens and I'll focus on specialty care as a surrogate for healthcare, maybe not a perfect surrogate, but if you look at specialty care in the U.S., and I'll define that as some of the large segments, orthopedics, cardiology, urology, gastroenterology, and oncology. That's not all the specialties, obviously, but that's often one that's looked at that has some private equity exposure historically in the last decade or so. Only about 6% of specialty care physicians are within a private equity backed practice. About twice that, 10 to 15% in still private practice. About half of the physicians are part of a hospital-owned practice, hospital-affiliated, and about a third of the physicians in corporate-owned. Corporate meaning owned by insurance organization or some other corporate entity like that. So roughly 80% are in that hospital or corporate-owned, and only about 6% in private equity in that specialty medicine. Within that, there's been a lot of study that's looked at when physicians move from traditional private practice to one of those other three categories. The greatest increase in cost is when to Medicare spend is when physicians move from private practice to hospital-owned affiliated practice for a whole variety of reasons. And we actually see in orthopedics a decrease in overall cost when moving into the private equity space. Now, the data, granted, they're relatively smaller data sets. We don't have millions and millions of physicians to compare, but the difference in magnitude and the difference in trajectory of those various categories is pretty clear. So to answer your question specifically, the data would suggest we haven't seen that in specialty care in as Jason mentioned in like in orthopedics, from physicians leaving traditional private practice going into a private equity affiliated organization. And lastly, I would say I agree that any business model or business plan that is ill-conceived and poorly executed is likely to have an adverse set of results down the road. A private equity organization investing in a factory, for example, and takes that fact as an investment opportunity and reduces the quality of the final product and reduces the experience of the personnel that work there, and makes cuts in a way that makes the overall sustainability of that factory and its product and its ability to grow less achievable, is likely going to do very poorly. And I think that's not necessarily a knock on where the source of funding comes from, but maybe how the source of funding is looking at the final product. And I agree, a short-term investment that with no consideration on long-term quality, sustainability, and in this case, the product being high-quality healthcare, is likely going to be very challenged to have a good product going forward.
Thank you. Dr. Blumenthal, would you like to weigh in?
So I just think that I don't want the listeners to come away with the impression that private equity is associated with lower price, because there's very little evidence of that. All the systematic peer-reviewed literature shows that private equity acquisition leads to higher price. There may be exceptions to that, as there are in oral social phenomena. There's always a bell curve of any social phenomenon with tails on both sides. But the studies that I trust that have been published in the major peer-reviewed literature have shown increases in price and reductions in quality. So that's point number one. Point number two is that, as I said at the outset, it's not the form of ownership that is at issue, it's the behavior and the association of behavior with that form of ownership. There are examples of private equity acquisitions that I think have made path-breaking changes in the organization and financing of care. Very positive ones. But there are equal numbers and more that have gone the other direction. And it's the balance between those two, the likelihood of a positive versus a negative outcome. Now, what predicts that likelihood? It's the motivation of the investors. There are likely to be investors who pick a community, see an opportunity to make a reasonable profit, and bring in new capital and new management talent. That is perfectly possible and happens. But on average, and in terms of likelihood, it is equally likely and perhaps more likely that people without a commitment to the community, the people that here may not have any presence in Wisconsin, but from a national standpoint are major actors. Well, Welsh Carlson is another one of them. Cape Car mentioned. A lot of the private equity firms that are using capital from high net worth individuals to try to realize better returns than they can get through other uses of their money, and promise their investors double-digit, triple-digit returns within a 3-year timeframe. That is a style of investing which has found its way into healthcare, which wasn't part of healthcare until a few years ago. It is new to healthcare, and it is exacting a price from local communities, because the only way to get that kind of return is to do things that extract value quickly. How do you do that quickly? You raise prices, you cut personnel, you sell the real estate. If you can, it's not typical of practices, but it is typical of hospitals. It's what Stewart did, sold the real estate. You saddle the facility with debt. The loans you take out against that property, you pay back to your investors. They go away. They've made their double-digit returns in 3 to 5 years. Then you sell the facility to another owner who tries to do that over again. That is so different. I was trained in a hospital that was founded in 1811, and it is still going strong. And I think that that commitment to community service, which has been characteristic of the best kind of medicine, take all comers, serve the community, provide a vital public service, is not part of the ethic of many private equity companies. They're not inevitably destructive. As I said, I know of some that have been very positive, but on average, their behavior is dictated by the requirements of their investors, and their investors want a return. Their investors don't know the community. They don't know Wisconsin from Texas, from Arizona, from North Dakota. It's all about the return. So I think that is just a reality. And by the way, I would also say, I think private equity is emblematic of a deeper problem in healthcare, which affects all types of ownership, nonprofit and for-profit alike, in which financial returns and growth have become more important than community service. And that is something that we all have to deal with in our local communities.
Thanks. John, would you like to weigh in?
Yeah, just quickly, just to follow up on Dr. Blumenthal's comments. There's an emergency room in Green Bay that doesn't take Medicare and Medicaid payers. I mean, I don't even know if that should be a thing, but it's a fact. They do not take Medicare and Medicaid. They aren't subject to EMTALA because they don't serve Medicare and Medicaid. They don't serve the underserved populations of that community. I don't think that's what we want. I mean, I know that's just one small example of what Dr. Blumenthal is talking about, but we lose money in our emergency room because we serve whoever walks through our doors. If you allow an emergency room to be set up that serves everybody except for the underserved, is that what we want as a state? That's a problem. That's definitely a problem. I would say historically, when ethics become a concern, profits over ethics in healthcare is when government becomes more involved. And I think that's where we're headed. That's, I think, part of Dr. Blumenthal's comments. I think if you have an ER that won't serve the underserved, we got a problem.
Thanks, John. You just mentioned government involvement. Tami, could you talk a little bit about what you would like to see, or what policy steps policymakers could take to address some of these practices?
Sure. I really feel like the conversation here is describing a moment for which I keep saying we are regulatorily unprepared. We really have a new landscape here where I would agree with Dr. Blumenthal that it isn't only private equity, it's also very large in the for-profit entity and nature of our healthcare system. Some of the same different players with different labels can have the same behaviors. And what we are kind of grappling with is we are now having players who operate in multiple states or perhaps across the country. And these entities are operating at a scale that's really beyond the ability of individual states to control or effectively regulate. There are some actions that states are taking, and I think it is telling that recently the U.S. Department of Justice, Federal Trade Commission, and the U.S. Department of Health and Human Services solicited input on the consolidation of healthcare markets, specifically on this issue, not only on private equity, but in overall, how are these larger players impacting access to care? There's some themes that are being discussed nationally and in comments and have been subject to some actions in states. First is basic transparency requirements. Who owns the settings? What's the profit margin? What's the breakdown on staff salaries and how money is being spent? Audits, those types of things, like where there are critical incidents or fines or corrective action plans. Do states know about that if they've happened in other states? Those types of things that might influence, what about what's happening on the ground, or if you accept an acquisition or deny it. There's certainly states that are looking at ways to how do we put some parameters on acquisitions. That's another strategy being used. Lots of folks are thinking about, should there be limits on expenditures that don't go to patient or long-term care? Is there an acceptable profit margin range? What's the criteria for ownership and operation of certain facilities? Consumer protections, how universal should those be? Are there prohibitive business practices that should be considered? And also in the home and community-based settings world, how do we make sure that capacity to provide care in people's homes is increased and ensured, so that especially vulnerable populations of people can receive support and care services, in their homes as long as possible before having to go into more intense services. Those are some of the things that are at a very high level that are being kind of contemplated as we're thinking about this kind of new scenario that we find ourselves in. And I think that one of the goals of the solicitation from the federal level is there's a recognition that these models that have led to greater consolidations, they've led to uncompetitive marketplaces, they've led to higher costs, loss of care options and services, and a shift away from serving everyone with need to those who can pay the most or who can pay it all. So I think that there is already recognition of some of the things that Dr. Blumenthal has talked about at a national level, and that John has talked about, and that we have seen as well. And there's certainly a feeling amongst, we haven't talked about individual people, but I think it does send a message when your local hospital, say in the Chippewa Valley, all of a sudden or services that you have access to are being closed because they are not profitable enough. It says something about how we think about the people who live in that area that really doesn't sit well, because where we talk about markets and access and choices, people who live in a specific area, they don't have unlimited access. They have to go with where they can get to in a geographic region that's served. And for lots of people, that access is being threatened now in ways that are pretty profound. So I think there's also a sense that, this isn't the topic of this webinar, but trust in healthcare is a recurring theme. And I think that one of the things that we're keying in on is that when people are starting to question whether a care recommendation or a place to live or other things are being made because it's the best thing for them or the most profitable for a company's bottom line, I think it really reinforces some of the fears that patients have had and that we see when they're thinking about engaging with the healthcare system. This is part, a further extension of trust issues. And at this point, there aren't a lot of ways that states or the federal government can really get a handle on, these relationships and what are these companies really in ownership of, and how is that ownership portfolio really impacting care?
Thanks, Tami. We're fast running out of time, and I have one sort of final question I want to pose to all the panelists. Trends. Do you expect to see, further private equity investment into the healthcare field? Do you think healthcare is trending towards becoming more for-profit? Tami, would you like to just start?
Well, all of us at some point will not be able to avoid that or escape the need for care. I mean, we're the supply side people. We're the constant supply of people who will need health and long-term care services. That's the constant revenue stream. And I think the question is how much profit each individual can contribute to businesses that own access to care. We already see that private equity is felt from fertility treatment to hospice, literally cradle to grave. I don't feel like at this point, without absent outside constraints, that there's any reason we wouldn't see these models continue to acquire assets across the healthcare continuum, because the supply side of people who need care is there and it is profitable. So from my perspective, we are perhaps on the front end of a trend as opposed to seeing it crest or decline.
Thanks, Tami. Rick, what do you think?
Yeah, I mean, the short answer for once in my life is yes. Okay, it is going to accelerate. But again, I believe that there's more positive than not so positive there. Again, at the end of the day, so long as that for-profit entity, not private equity, for-profit entity, okay, is committed to the community, is committed to providing quality, is committed to providing economies of scale, more resources, okay, to an entity that's struggling both operationally and maybe financially, that's a good thing, not a bad thing. And all of us in the healthcare community, okay, not just regulators, okay, and not just policymakers, we have a stake in ensuring that the quality of care, and again, I'll speak to my sector, long-term care, but really across the continuum, the quality of care remains high. Because if we have got a player that doesn't believe the same, that hurts all of us, most importantly, the citizens and the residents of Wisconsin.
Thanks, Rick. John?
Yeah, I mean, I think as long as there's 20% to be made in the market, private equity will jump in and try to make that money. I think the thing that we also need to talk about is when there isn't 20% to be made, they tend to move their money somewhere else and walk away from the market, which can be very detrimental with the wake left behind that. And I think Stewart is an example of that, which Dr. Blumenthal brought up, a very alarming example of that.
Dr. Sansone?
I wish I had a crystal ball. It would help. It would help a lot of things. But I don't know. Is the trend toward nationalizing healthcare more? Right? Is the trend toward the government stepping in and I don't know what the right answer is, quite truthfully, to stepping in to create a larger public safety net and to eliminate the kind of the for-profit nature of some healthcare practices, or is the trend in the other direction? I think, I try to manage my little corner of the world as best I can and treat patients every day on a patient-by-patient basis. It'll just be interesting from my chair to watch and see what these trends evolve over the state and national level.
Thanks, Doctor. Dr. Scalise.
Yeah, I guess I would say the trend that I want to see is a continued, serious, meaningful investment of time, resources, and thought around solving the chronic issues that we have in our American healthcare system that were brought up earlier. Very high spend in healthcare, far less than ideal outcomes, and that embarrassing state of affairs, frankly, is longstanding and predates the relatively recent influx of private equity funding into healthcare. And so I think what we have to, as a healthcare community and as a nation, have to focus on what things are going to be able to help sort of chip away and correct that very bad trend of high cost and low reward. Otherwise, in many ways, some of these discussions can be somewhat academic because we have real problems to solve. And so hopefully, I think we look at a serious investment of people working together to try to help solve some of these challenges, in investment even from government organizations to help solve where we are.
Thanks. And Dr. Blumenthal, I'll give you the final word.
Well, I'm going to go in a different direction. Private equity is about return on investment. Very simple. Return on investment, cold calculation. Anything that reduces that return on investment will cause it to go elsewhere. I think Dr. Scalise made that, or Mr. Russell made that point. Interestingly, probably the most important determinant of the profitability is the interest rate. So the reduction in interest rates recently means that the cost of investment generally in all sectors has gone down and will continue to go down. Private equity investment was falling last year. I think it's going to pick up again because the cost of money has gone down. So they don't have to make as much money in increasing prices of healthcare, reducing quality, reducing the number of personnel in practices in order to make a good return. So I think there's going to be a bump again in investment because the cost of investing in healthcare and elsewhere has gone down. I don't think private equity is the solution to our chronic healthcare problems because it is not wholly, but has elements that are extractive and take resources out of healthcare and put them in the pockets of people who aren't in healthcare. And they do that because they see a crease in the marketplace, an area of market failure that they can exploit. And so I think there'll be more because the cost is less, but that will taper out over the next 5 years as more and more regulation gets in the way of what is considered, not always, not in all cases, but in enough cases, to be an abuse of a public-oriented public service.
All right. Well, thank you all so much for participating in the panel. And thank you for staying a few minutes afterwards to kind of round off questions. Really great discussion. I feel we could talk about it for hours still. So thanks again and have a great day, everyone.
Thank you.
Thank you all.
Thanks.